Hi, good evening. Welcome to Hospital for Special Surgery and our program for this evening, the Rheumatoid Arthritis and Oral Health Connection, What You Need to Know. My name is Adina Batterman. I'm the Senior Manager of Inflammatory Arthritis Support and Education here at Hospital for Special Surgery, and I want to extend a warm welcome. I'm going to be your moderator this evening. It's my great pleasure to start the program and to introduce the topic and our esteemed panelists. The topic, as I introduced initially, is the Rheumatoid Arthritis and Oral Health Connection, What You Need to Know. Before we start, I also want to acknowledge our wonderful co-sponsor and partner in this venture, and that is Creaky Joints. And we just want to thank them for their participation, their support, and valuing this type of programming. So first, I'd like to introduce our panelists. Our first panelist is Arthi Kumar. Dr. Kumar is an oral and maxillofacial pathologist at NYU College of Dentistry and Interfaith Medical Center. Dr. Dalit Ashany is an associate attending rheumatologist here at Hospital for Special Surgery and also an assistant professor of medicine at Weill Cornell Medical Center. Welcome, both of you. I just want to kind of give an overview of why we're here and why we invited both of you from these different disciplines to talk about this issue. We want to provide some information about the connection between oral health and rheumatoid arthritis, as the title would suggest, but also highlight the collaborative nature of somebody managing rheumatoid arthritis and their rheumatologist, and often other specialists who are involved in their care. So that, and in this case, an oral and maxillofacial pathologist, so you can best manage your oral health and therefore manage your rheumatoid arthritis overall. So with that, I thought perhaps we would start with Dr. Kumar. Can you tell us a little bit about what you do, Dr. Kumar?
Thank you, Adina. Just to let you know, the type of work I do is, even though I have a dental degree, I have extra training, 3 years actually, in a residency where I learned about, of course, pathology, which you all know what a pathologist does, looking under a microscope at tumors, infectious diseases. But I also treat people in the clinic when they have problems with the skin of the mouth, almost like a dermatologist of the mouth.
Thank you. And Dr. Ashany, can you tell us a little bit about what you do in the treatment of rheumatoid arthritis here at Hospital for Special Surgery?
Thank you so much for including me in the program. I am one of the staff rheumatologists. I primarily see patients with rheumatoid arthritis as well as other autoimmune rheumatologic conditions. In addition to patient care, which is primarily what I do, I also participate in research studies, clinical research at this point in my career in rheumatoid arthritis, as well as in some of the other inflammatory arthritis conditions.
Thank you both for being here. So I thought we'd start off with Dr. Kumar as an oral pathologist, just so that we have an overview of what we'll be discussing today. From your perspective, what conditions or issues you typically see in people with rheumatoid arthritis, and then we'll go by those point by point later in the program, throughout the program.
Okay, just to give you a little overview, there are really 4 main categories of problems, and we will be going into depth on each of these. The first one is the relationship of rheumatoid arthritis with periodontal disease. As you may be aware, periodontal disease affects the structures which hold your teeth in place. Next, temporomandibular joint disease. This is the joint, the hinge joint, which holds your lower jaw in place. And then Shoguns Syndrome, which really is another autoimmune condition where people have symptoms of dryness. And finally, the side effects of all the treatment that you are taking, which may cause oral manifestations.
Thank you. So I think that's a good launching point for starting our talk. Dr. Ashany, I'm wondering, let's start with periodontal disease. I think many people with RA are surprised to learn that there's a connection between RA and periodontal disease. So I thought maybe we'd start with a brief overview of RA and how it's related.
So thank you, Dina. I think many members of the audience know what rheumatoid arthritis is, so I'll make a few brief statements. So it is a chronic autoimmune disease, which is primarily, but not only, characterized by inflammation, and by inflammation I mean swelling and pain and eventual deformity in multiple joints. We don't really know for sure what causes rheumatoid arthritis, but we do know that it is a combination of genetic factors, but also environmental triggers, although we don't always know what that environmental trigger is. Having described what rheumatoid arthritis is, how do I know, or how do I think about rheumatoid arthritis? How do I diagnose it? So it's a combination of a few different features. One, of course, is to listen to the patient's history of symptoms. They're coming in with joint pain. What is the quality of the joint pain? Which joints are involved? How long have they had the symptoms? What other symptoms other than joint pain do they have? Another component of making the diagnosis is the physical exam. So in rheumatoid arthritis, we expect there to be at least one swollen joint. The joints that are most commonly affected in rheumatoid arthritis are the small joints, so that would be joints of the hands, the feet, the wrists, but that's not to say that other joints can't be affected as well. A third component of making the diagnosis is blood tests. So there are two antibody tests. These are autoantibodies that are important in rheumatoid arthritis. One of them is the rheumatoid factor, which despite its name is not very specific. We can see it in other diseases as well. And then an antibody called the anti-CCP antibody. And that antibody is highly specific for rheumatoid arthritis. So not 100% of the time, but over 90% of the time, if we see an anti-CCP antibody in somebody with typical joint symptoms, the likelihood of rheumatoid arthritis is quite high. Just to be complete, other blood tests include inflammation markers, sedimentation rate, and CRP. And of course, other studies, radiographic tests such as X-rays, MRI, ultrasound can also help us make the diagnosis. So I mentioned the environmental risk factors as being important, and many times we can't identify a risk factor, but we do know of two very definitively. One is smoking, and the second is the subject of our discussion tonight, periodontal disease. So why does periodontal disease have anything to do with rheumatoid arthritis? So what periodontal disease is that there's tissue damage in the mouth, and that tissue damage seems to occur because the immune system fails to control the normal bacterial community in the mouth. And then the immune response to that bacterial community can cause damage. Certain bacteria that live in our mouth do seem to be important in their relationship to rheumatoid arthritis. So one specific one is P. gingivalis. In its function as a bacteria, it apparently can change the proteins in our mouth, which leads our immune system to make anti-CCP antibodies, that same antibody that I mentioned before that is highly specific for rheumatoid arthritis. And so there is one important link between periodontal disease and rheumatoid arthritis, and Dr. Kumar will speak more towards that point.
First of all, just so you can appreciate what periodontal disease is before we continue on, just like Dr. Ashany said, it's really the inflammatory process which occurs around the tissues that hold your teeth in place. And so just to give you an idea, if you look on the right side, there's a grouping of teeth where the bone level is high up. So here you can see the bone is high up. And then when we go to the left side, we can see that the bone has sunken lower, okay? This is a This is a consequence of periodontal disease, which is really just the supporting tissues start to break down. And as a result, we have teeth which become loose and they start to fall out. Now, one of the things we want to make you aware of is that this problem occurs has a higher prevalence in people with rheumatoid arthritis. Even though it is fairly common in the general population, when I saw the statistics from the CDC, it's about 47.2%. But some studies have indicated that this occurs almost 2 times more likely in rheumatoid arthritis patients. So the challenge here is really to understand why, of course, why this happens, and also just so that you are aware of your periodontal status, because your periodontal disease in the early stages is really not symptomatic. Okay, so it's important for you to just know, have x-rays taken, confirm where your teeth, how they look, just so you know that by taking care of them, by going to see the dentist regularly, you remove irritants which can ultimately lead to better oral health. What are some of the things you can do? Make sure you see the periodontist. So just to give you an overview about what you should do in terms of managing something like this, really just know where you are in terms of your periodontal health. And just like I said, I don't treat periodontal disease, but this is one of the facets that you need to be aware of in terms of oral health and rheumatoid arthritis.
Dr. Kumar, can you share what your thoughts are about people with RA and how often they should be visiting their dentist to make sure that they're minimizing the risk of periodontal disease?
Yes, of course. That's a great question. It's important to first know what your periodontal health is. So you need to have an initial visit. And after that initial visit, the dentist or periodontist determines whether you need to be seen every 3 months, which is someone with active periodontal disease, or if you have no issues, they will determine, the correct interval, which could be 6 months to a year, depending on your oral hygiene, depending on other factors such as, how serious your rheumatoid arthritis is. So this is really very individually tailored.
Okay, thank you.
Mm-hmm.
We're moving from periodontal disease to another issue that Dr. Kumar highlighted in her overview. That issue is temporomandibular joint dysfunction, or commonly known as TMJ dysfunction, as a condition sometimes seen in people with rheumatoid arthritis. Dr. Ashany, I'm wondering if you can start off by explaining what TMJ dysfunction is and how often it occurs in people with rheumatoid arthritis.
So the TMJ joint, which is in the jaw, as we've highlighted, is a joint like any other joint. It's a synovial joint. So in the same way that the small joints of your hands can become inflamed, the autoimmune process of rheumatoid arthritis can also attack the temporomandibular joint. Now, TMJ arthritis is a common condition amongst everyone, whether or not they have rheumatoid arthritis. So many of my rheumatoid arthritis patients may be developing TMJ arthritis not because of their rheumatoid arthritis, but because of all of the factors that come into arthritis occurring in the joint. So that's a little bit of a difficult distinction. Is it coming from rheumatoid arthritis, or is it coming in the same way that somebody without rheumatoid arthritis may develop TMJ? Mm-hmm. So as a rheumatologist, when somebody first comes to me and says, my jaw is hurting, In either case, we would first start with conservative measures. And so I would recommend not eating hard foods, not eating chewy foods, all the usual. I think maybe Dr. Kumar will be speaking more to that as well, but there are many conservative measures to take. If it becomes a question of, could this be my rheumatoid arthritis? Do I need to increase my rheumatoid arthritis meds because the rheumatoid arthritis is affecting my TMJ and we're not controlling the disease well? In that situation, I would refer the patient to a TMJ expert. There are such people, and they might order a CAT scan or an MRI of the TMJ joints, and then the radiologist can sometimes distinguish between what looks like rheumatoid arthritis on that scan versus what might look like degenerative disease of the joint, such as happens in anybody.
Thank you. Dr. Kumar, who are the specialists who treat TMJ dysfunction, and how is it typically diagnosed and addressed in your area of expertise?
Yes, so this is also a very specialized area. So as an oral pathologist, I don't treat this, but there are specialists called orofacial pain specialists. And oh, it looks like I will talk about this slide after I introduce so the orofacial pain specialists, they focus on the joint, the temporomandibular joint. And as Dr. Ashany alluded to, they do certain imaging studies, such as something like what we see here in this MRI, where you could see on the left side the healthy joint, and it's a little bit more rounded. And on the right side, we have a little, yes, thank you. And on the right side, we can see that the joint is a little more flatter and it has a sharp edge to it. And there are some other alterations here, but these are the things that are typically looked at by an orofacial pain specialist. So these people are not commonly, there are not very many of them. So you would probably, they are tied with like academic institutions. So they, that might be a place where you may find these people. But first of all, once you have symptoms, you mention it to your rheumatologist, like Dr. Ashany, and she will help you make those connections with these specialists.
Dr. Kumar and Dr. Ashany, can you share some takeaways you can offer to someone experiencing TMJ dysfunction? I think you started, Dr. Kumar, by mentioning, and this is an important thing to highlight, to speak to your rheumatologist and let them know of the symptoms you're experiencing so that you can be managed either with your rheumatologist or referred to another specialist to help.
I'm happy to address that more specifically. So if a patient comes to me with symptoms that I think might be related to their TMJ, and by the way, those symptoms can be headache. Sometimes people don't even realize that the source of their pain is coming from the temporomandibular joint. Some people experience ear pain. So you really have to kind of, think about the possibility that it might be TMJ. On physical exam, pressing on the joint and eliciting pain is one way to tell if a person has the TMJ. Asking them to open their mouth wide and asking them if they hear creaking in that joint or if there's pain when they do that is another way. So if it's obvious to me that it's temporomandibular joint pain, then the customary treatments that we use are to take anti-inflammatory medicines like Advil or Aleve if possible, to use warm soaks. Preventative measures are, as I mentioned briefly before, not to eat hard or chewy foods, not to open the mouth wide. So I say to people, avoid large sandwiches, avoid bagels, eat soft food for a while. And with time, for most people, the symptoms will diminish and improve with those interventions. As I said, if they don't, then, and by time I mean a few weeks. If they really don't, or if they're getting worse, then I would refer to a specialist that Dr. Kumar was speaking about. Sometimes it's not obvious to me. If a patient has ear pain, I might end up referring them to an ENT because somebody has to look in their ear to make sure that it's not actually an ear problem. So that is my general approach towards the temporomandibular joint. I did want to just mention that it's not that common a joint to be affected in patients with rheumatoid arthritis. It is more common in our kids who have juvenile inflammatory arthritis. We see it more in them, but it can happen.
In your initial slide, Dr. Kumar, you mentioned one of the conditions that can co-occur with rheumatoid arthritis. So I was wondering if Dr. Ashany first can talk a little bit about Shoguns Syndrome, which is a condition that can affect people with rheumatoid arthritis. So what is it, and what is its relationship to rheumatoid arthritis?
So Shoguns disease is an autoimmune condition where the target of the autoimmune attack are glands. So primarily, or most commonly, the glands that are attacked are the tear duct glands. So people will present with dry eyes, as well as the salivary glands, which means that the individual doesn't make as much saliva as they should, and that manifests as a dry mouth. Some people, Shogun's disease can be secondary, meaning that in a patient with known rheumatoid arthritis or even other autoimmune diseases such as lupus, it can coexist. So if a patient has rheumatoid arthritis and then develops dry eyes and dry mouth, then it's considered secondary Sjogren's. There are people who don't have rheumatoid arthritis or any other autoimmune condition at all. Their only autoimmune condition is Sjogren's disease. They will have the same symptoms of dry eyes and dry mouth, but they won't have rheumatoid arthritis. They don't have the joint pain or the joint swelling that we associated with RA. Regardless of whether it's primary or secondary, the treatment for Sjogren's is the same because the medications that we give for rheumatoid arthritis don't help us with improving those dry symptoms, the dryness of the mouth or the eyes. So those symptoms have to be treated locally. In people with primary Sjogren's, they may not have to be on any medications because, again, the medications won't help the symptoms that are bothering them most, which is the dryness. And so there are many interventions that we can make to help with those very annoying symptoms. And I think that we'll be speaking more about that in a few minutes. But that is what Sjogren's disease is.
Dr. Kumar, if you could speak a little bit about, so we have an overview of Sjogren's and the condition itself. Can you speak a little to the impact of Sjogren's on the teeth, the gums, and the mouth, and why this is a condition that is treated by rheumatology, but also in your area of expertise?
Yes, thank you. So when you think of having a dry mouth, you think of that discomfort because now your tongue is not moving smoothly over your teeth. You have difficulty speaking. So these are the common subjective symptoms that patients come to us with. They just feel like food doesn't taste as well as it used to. So one of the things is really just the physical absence of having the lubricating effect of saliva is now gone. And so when you have your mucosa or the skin of the mouth move over rough food or teeth, sometimes it can actually get injured. So that's one thing. And the other thing, now moving into another area, is the decreased buffering capacity of saliva. So when your saliva is not present, now when you have acids and bases from food that you eat, it can actually cause the mouth to not be able to take care of when you eat sweet things. So now you end up with more cavities. Okay, so the buffering capacity of your saliva is very important for making sure you don't get cavities. And people get cavities actually in different areas when they have low salivary flow. It's actually on the smooth surfaces of the teeth. Different from what you think. Normally people get cavities in the grooves of the teeth, but this is an indication to us that the person has very low salivary flow. The other thing that can happen is once the salivary flow has decreased, the normal bacteria in your mouth or bacteria or fungal organisms, there is a change in the actual balance, and so you end up with fungal infections. The most common one of the ones that I treat on a regular basis is candidiasis, intraoral candidiasis. And the last area just to touch on is the low salivary flow can also be a contributor to periodontal disease.
Just in terms of the diagnosis of Shoguns syndrome, sometimes we have patients who have had symptoms for many years and nobody has considered it. Older people can also have dry mouth and dry eyes as a symptom of aging, but on occasion, an older person will develop Shoguns syndrome. And it's important to know because occasionally there are other manifestations of Shoguns disease. Sometimes people get joint pain and other organs can be affected. So it is important to make the diagnosis. The primary way to make the diagnosis is, of course, a person must have some form of dryness, usually either dry eyes, dry mouth, or both. So if somebody comes in with those symptoms, then there are certain antibodies that we check that would more highly suggest that the patient has Shoguns disease. So as a rheumatologist, I would send the two antibodies called Shoguns Syndrome A, also known as anti-Rho, or Shoguns Syndrome La, also known as Shoguns Syndrome B, also known as anti-La. Also, rheumatoid factor is very highly expressed in Shoguns syndrome. Now, having said all that, there are a certain percentage of patients who have Shoguns syndrome who don't have these antibodies, and I think Dr. Kumar will be speaking a little bit about other diagnostic tests as well as touching upon these laboratory studies.
Dr. Kumar, can you share a little bit about your diagnostic process?
Sure, yes. So some of the things that are done are taking just a very simple test is really just having a person chew on a sugar-free type of piece of wax, or it's called a salivary flow test actually, and they chew, and then you actually just collect the saliva that develops in your mouth in a little in a cup and just measure it. And this will tell us if you stimulate your glands, are you able to make saliva? If not, we know that there's something wrong with your glands. And so then there may be the next step of having something called sialography or salivary scintigraphy, where a dye is injected into the gland and imaging is performed, and the specific pattern that results helps to make the diagnosis. And then the last thing, which is a little more related to myself, is called a lip biopsy, where if you feel your lip, you have these little nodules in your lip. Those are actually your minor salivary glands, and that's what keeps your mouth moist. Few of those may be removed in a small procedure called a biopsy, and then it's looked at under a microscope, and then it adds to the possibility of this patient having Shoguns syndrome. So you need to actually have numerous things as Dr. Ashany, of course, would know, that all these things have to be put together. It's not like you could take one test in isolation and make any diagnosis from that. So, because sometimes there are false negatives. And
Thank you. So now we have a little bit of background about how Sjogren's is diagnosed, and that sometimes it takes a while and it's difficult to diagnose. But once it's suspected that there is Sjogren's, if you can share a little first with Dr. Ashany and then Dr. Kumar, how Sjogren's is managed, first from a rheumatology perspective and then from uh, an oral pathologist perspective.
So, Dr. Kumar has put together this slide of how Sjogren's is managed. And so, I will ask her to speak to it. But as a rheumatologist, as I said, there are no medications. You do not suppress the immune system as we do for rheumatoid arthritis in order to treat Shoguns syndrome. It's all local treatments to the eye, if that's the case, local treatments to the mouth, if it's the dry mouth that is bothering the individual more. In terms of the mouth, I think we all see this slide here. So typically I will just start by telling people to hydrate as much as possible. Sometimes we recommend sugar-free lemon drops because that stimulates salivary flow. On occasion, I've recommended something called an Oromoist patch, which can stick to the roof of your mouth and can be used at night if you're having a lot of dry mouth at night and waking up with very uncomfortable symptoms. There are also medications that can stimulate salivary flow, and Dr. Kumar will mention those as well. So those are the general approaches. Biotin also, Dr. Kumar will discuss. Again, local treatments, nothing to do with suppressing the immune system, which is what we have to do to treat rheumatoid arthritis.
Thank you. Dr. Kumar, can you elaborate a little on this slide and manage these types of areas of management?
yes, thank you. So typically, exactly as Dr. Ashany indicated, really just treating the symptoms to try to make the person feel more comfortable. So these sugar-free, so it's important that what you use is sugar-free so that you don't end up with the problem of more cavities. So there are things called sugar-free sialogogues, and that really is just a term for something which stimulates your saliva. So you could use those, or artificial saliva is available. It's just good to know that you need to find what works for you, because we do hear patients who say, I've tried everything. I don't really like this artificial saliva. I prefer this. So it's good for you to try all the different things, and then you can find what is actually more comfortable for you to use. There's even this medication, pilocarpine, and another medication, cimevaline, which can be used, and it is used for some people. And the only problem with this medication is there can be side effects, and sweating is one of them, and you see other ones written there. But it doesn't happen to everyone. The side effects don't happen to everyone. So it may be worth it for you to try them and see if you are one of those people who don't get the side effects. And finally, the topical, which means just placing this medication directly in contact with the skin of your mouth, topical antifungals, which are used to treat candidiasis, or, as I explained earlier, the yeast infection, which could occur due to the change in the balance of the organisms, in the normal organisms in your mouth. Okay, so sometimes we do prescribe that fairly frequently.
Dr. Kumar, can you share a little more about any recommendations about medications to avoid and other management issues that would be important as a takeaway for people listening?
Yeah, sure. So now these are just guidelines, like try to avoid medications that end up drying you out. However, if you do need to take these medications, we don't really want you to change anything. It's just be aware that There are many medications that cause dryness, such as antihistamines, some antidepressants, and even decongestants. So, if possible, you may consider, not using them. However, this has to be done in consideration of your medical condition and why you're taking them. The other thing, if you are wearing dentures, you really need to make sure that they stay nice and clean so that you don't end up with a fungal infection because you're dry and now your denture is not being cleaned. And you really should know this, but we like to, we see it all the time where people wear their dentures continuously, which leads to soreness, fungal infections. So remember, if you are wearing a denture, to remove it and never wear it overnight.
Thank you. Dr. Ashany, do you have anything to add to that before we go on to the next area?
No, I think that's in terms of the oral health and in terms of the symptoms, I think we've covered what we can do.
Mm-hmm.
I will just say that I do have patients who successfully use pilocarpine or cevimeline. They're dosed as 3 times a day or 4 times a day, and then people may have unacceptable side effects, but some of my patients find once a day or twice a day is a perfect balance of just improving the salivary flow a bit so that they're comfortable and not having to suffer the unpleasant side effects. So I do keep it in mind for people who don't respond to the more conservative measures that we've mentioned.
Thank you. I just want to also underscore, because I think it's an important point, Dr. Kumar, that you raised. So these are recommendations and guidelines of medications that perhaps have a side effect of dryness, and to try to avoid that when possible. But it's so important. And again, we're highlighting communication with your rheumatologist and with your oral pathologist or dentist. To have that discussion with them before you discontinue any medication or you start any medication, because everybody has a unique clinical picture, and the benefits and risks need to be weighed in that conversation. So we're going to move on to the next area that you highlighted, Dr. Kumar. There is, we know, there are side effects and there are connections between the medications we use to treat rheumatoid arthritis and oral health in many different ways, and we're going to highlight a few of those. I'm wondering if Dr. Ashany, if you could start off with telling us a little bit about some of the medications that you typically prescribe for rheumatoid arthritis that might cause some oral side effects or issues.
Sure. So for rheumatoid arthritis, the first 2 drugs are 2 of our older medications. Methotrexate is really the medication that we still use first for many, many RA patients, and we use it for a majority of our rheumatoid arthritis patients. Methotrexate is a global immunosuppressant medication as opposed to more targeted treatments, which are the biologic agents, which I've listed as the 4th bullet point. So methotrexate can be very effective for rheumatoid arthritis. We've had experience with it since the 1980s, and so we consider it a safe medication. We use it quite often. One of the potential side effects of methotrexate is that for some people it can cause oral ulcers, which everybody gets an ulcer from time to time. If you've accidentally bitten your mouth, your oral mucosa, you might get an ulcer. So there's shallow ulcers which are painful and they can make eating difficult. So we warn patients that this can happen, and we ask patients to let us know if it does happen. And if it does happen with methotrexate, and again, it's not the majority of patients, it's really a minority of patients that have this problem. But when it occurs, sometimes we have to stop the medication. Sometimes we find that if we lower the dose, we can still gain some efficacy for the medication, and the patient no longer is suffering from the oral ulcers. So that's one of the medications with a potential oral side effect. Hydroxychloroquine, also known as Plaquenil, which, as we all know, has been in the news quite a bit during this time of the COVID pandemic. Given to patients with rheumatoid arthritis who have relatively mild disease, this is a side effect that is listed. It is extremely uncommon in my experience, hyperpigmentation. It seems to happen, if it's going to happen, in people who have been on the medication for a very long time. This hyperpigmentation can happen in the skin. It can happen in the back of the eye, in the retina, and that is why those of you on Plaquenil know that we send you to a ophthalmologist every 6 months to 12 months to make sure that's not happening, because that can have a consequence of blindness. But fortunately, we can screen for it and stop the medication if we see it. And again, it can also happen in the mouth. So that could be a alarming thing for somebody to suddenly see a black discoloration in their mouth. So it's important to be aware of that. Steroids, prednisone, methylprednisolone, Medrol, we all know them. We love them because they can treat symptoms so quickly and make people feel better so quickly, but these medications have a lot of side effects, and so we limit their use significantly, only if we absolutely need to. And in terms of the mouth, because they suppress the immune system so intensely, they can cause the candidal infection that has been mentioned before by Dr. Kumar, also known as thrush, and so then that has to be treated. I've lumped all the biologic agents together. So by biologic agents, I'm talking about many of them injectable medications such as the TNF inhibitors, IL-6 inhibitors. There are many of them. These agents, more than the methotrexate or hydroxychloroquine, increase our risk of infection. And so with that, with increased risk of infection, patients may develop an overgrowth in their mouth of abnormal bacteria, or they may develop an infection if they've traumatized the mouth by biting accidentally the mouth, for example. They may be at increased risk of that becoming a more serious problem with infection. So those are the rheumatoid arthritis medication overlap with oral health that I would want to highlight.
Before we go on to the next slide, and Dr. Kumar, since you're raising the issue of people who are taking biologic agents and the increased risk of infection, just the overlap with dental surgery and procedures, and what you usually speak to your patients about when they're contemplating or they need to have some type of dental surgery.
Yes, thank you for asking that question, Adina, because it is important. Before any procedure, any invasive procedure, because these medications increase your risk of infection, and because invasive procedures predispose you to having an infection, we, as rheumatologists, we do want to know before you have surgery, you have to let us know the different biologic agents. They all need to be stopped before surgery. Methotrexate, hydroxychloroquine do not need to be stopped, but the biologic agents too, because they clearly increase the risk of infection during surgery. Depending on which agent you use will determine how far in advance you might have to stop it. So a weekly agent can be stopped 2 weeks in advance. Something that's given every 2 weeks would be stopped 3 to 4 weeks in advance. We need to allow that agent to leave your system so that when you're having the surgery, it's no longer present. And so your risk of infection then goes back down to what somebody who's not taking the medication would have.
Thank you. And just underscoring again the importance of having these communications and these conversations with a rheumatologist and also with an oral surgeon.
Yes.
Thank you. Dr. Kumar, can you share a little bit about how often you see oral manifestations or health issues related to RA medications? What are they, and how often do you see them?
Yes, thank you. So Dr. Ashany alluded to quite a few of the usual manifestations that we do see, which includes the ulcerations and the pigmentation, even though in my short career so far, I haven't actually even seen that yet. So it's very rare, as she indicated. But we do see the ulcerations from the methotrexate, and also something else is there is a very specific type of reaction called a lichenoid reaction, which is a reaction to drugs. And these lesions aren't really obvious because they don't always cause pain, but I have seen that. They just look like little white lines on your cheeks. So it's nothing to be alarmed about, but these are some of those rare side effects of medications. And that is something we usually do see and treat if they become erosive or ulcerated with a topical steroid. And finally, the candidiasis, which was already mentioned, and I think that covers it.
Thank you. Thank you. I do want to ask if you have any pearls of wisdom, take-home messages. If people walk away from this webinar with any specific or basic information, what would that message be?
What I would say is really just let someone know if you are experiencing oral issues. Just start talking to people and letting them know, because only then you will realize, oh, this is actually commonly encountered. Let your rheumatologist know, and they can send you either to me or manage it themselves, or we send you to a dentist, periodontist, orofacial pain specialist. It's really just being vocal and working with your healthcare team.
Yeah, and I would, of course, have to echo that. You know, when we start when we start our patients on medications, we try to make them aware of potential side effects. Sometimes it's a laundry list. Sometimes it's hard to absorb everything at the beginning. And so the takeaway message is that when you have a systemic disease like rheumatoid arthritis, it's important to, you know, if you're concerned about something and you're not sure, is it related to my rheumatoid arthritis or not, you just have to speak to your rheumatologist, because we've been living with this disease through our patients, in my case, for over 30 years. Some of my patients have been living with it for a few months or a year. There's no way you're going to be able to know. And so don't hesitate. Send an email, pick up the phone, make an appointment. You have to communicate. Communication is very important in having a chronic disease. And so you have to rely on the people who have known the disease for much longer than you have to help you figure out, is this something abnormal? Is this related, or is it not?
So we have a number of questions. So one person asks, and this relates back to an earlier slide, what does P. gingivalis do?
It's the actual bacteria that's present in the periodontal tissues. Okay, so that's a type of bacteria, P. gingivalis. And it actually, I will let you go on with the auto antibodies.
Yeah. So
Mm-hmm.
one question for me, because I don't think as a rheumatologist, periodontal disease is not front and center for me. I have to be honest about that, because there's so many other issues that happen more commonly and are, you know, more important in the moment. So P. gingivalis, I believe, is a normal component of a bacterial. Yes. So P. gingivalis is the name of the bacteria, which is found in the mouth. And if it's not overgrowing, if it's not overexuberant, then we're fine. It's interesting because it turns out that this particular bacteria has a relationship to that anti-CCP antibody that is so important in RA, in that it's so specific for rheumatoid arthritis. So it makes us think that somehow it must be related, because this highly specific antibody is caused in a way by this P. gingivalis. And I think there have also been studies that have found it in the synovial fluid, in the fluid that accumulates in the joints of rheumatoid arthritis. So we're always looking for what is causing this disease. And so when we have a hint, a big hint like that, we try to look into it. We try to figure it out. Is there a way to detect it or detect higher levels? And this, I'm just talking off the top of my head now. It is a jumping off point for more research and to try to gain more of an understanding of why our patients, what might drive it.
Thank you. As a follow-up to that, there's another question similar to this having to do with CCP antibodies. Dr. Kumar, are there treatment differences in periodontal disease that occurs because of the anti-CCP antibodies versus other reasons for periodontal disease?
So treatment reasons? No, the treatment is really the same. We just want to make sure that anything that could elicit any type of immune response is removed. So it's really the best treatment is to mechanically remove and clean out whatever debris has accumulated in the area between your tooth and the tooth socket.
Thank you.
Mhm.
So we have another question. You just spoke to mechanical treatment. Somebody's asking here about managing rapidly declining oral health with increasing loss of ability to open one's mouth and overcoming dexterity issues with oral hygiene and flossing, which is a real barrier and obstacle in keeping oral health
Mhm.
or managing oral health. Can you speak a little to that?
Yeah, sure. So first of all, some nice um, there's some nice handles that are a little easier to use on toothbrushes, or they're actually toothbrushes sold with larger handles. We just need to connect you with that resource. So you could bring it up even with Adina. She could help you to find that. Okay, so those are special toothbrushes with nice larger handles, special floss holders, and electric toothbrushes. You could use electric toothbrushes. And then as for opening and closing, it is complicated. So this is why you need to make sure you may need to have some help to have a very thorough cleaning on a regular basis, just getting help from a dentist or
Yes.
hygienist. So to keep up with everything.
Yes. Somebody also mentioned or asked about water picks for interdental areas, especially for people who are having difficulty um, uh, flossing.
It's a great idea. Great.
Okay,
Everything you can do will help. Though the water picks are a good idea.
thank you.
I would also mention that in rheumatoid arthritis, if somebody has severe TMJ pain, or our children who have had severe TMJ disease and now are adults who I see sometimes, opening the mouth and being able to go to a dentist who can deal with that. Not every dentist can deal with that. So I think it's important for our patients to know, how do you find a dentist who is comfortable working in a mouth that doesn't open very much?
Yes.
Yeah, so this is actually a great point. You would need to go to a place where people know about these things, such as a special care dentist in some cases.
Mhm.
They take care of individuals with just other extra needs, and they understand, and they don't have a day which is full of patients, so they're trying to get through very quickly. There are people called special care dentists, and they actually take care of individuals with unique needs.
Mhm.
So you may need to be in touch with someone like that.
Um, and who would one ask about how to find or locate, if you know?
Oh, yeah. So I guess you could ask your dentist right now, or you could, I mean, at our, academic institution at NYU, we have a state-of-the-art facility for special patients
Mhm.
tailored to their needs, all the different needs.
If you have yeast in your mouth, can
Mhm.
that result in sore cracks at the edge of your mouth? What are the symptoms when you have an oral yeast infection?
Yeah, so that is one of the signs of yeast infection in the mouth. Those red cracked areas, it's actually called angular cheilitis, and that is typically something I would see in the oral medicine clinic. and typically treat it with a topical or like a paste that you place right in that area. And in some cases, if it doesn't go away, we may give you an intraoral topical so that when the saliva pools in that area with the yeast, it's coming from intraorally. So there's different ways to treat this, but that's one of the things that can happen. The other one is you get these white plaques, just little areas of white that can peel off. Okay, so it's called a pseudomembranous, or a thrush is what that's called. People can get fungal infections under their denture. That's when they don't remove it and their mouth is dry. And then the last type, which isn't as obvious, is when the mouth becomes red and sore and sometimes ulcerated. It's called an erythematous candidiasis. So it's really these 4 manifestations of yeast infections that we see.
Thank you. So I want to thank our panelists for giving some very basic but also some very detailed information about the importance of oral health, how to maintain oral health and its relationship to rheumatoid arthritis. And also highlighting in many areas, we talked not only about oral pathology and dentists and rheumatologists, but we also spoke about other disciplines, physical therapists, specialized physical therapists, ENT. It really is a conversation between many specialists when you have RA. So just wanted to underscore that. Thank you both. I feel this was very informative. If there are additional questions and you put them in the Q&A, we will try to answer them at a later time. But this concludes our webinar this evening.